First, I get to introduce Robert Roose. Many of you know Dr. Roose. He's Vice President of Mercy Behavioral Health Care, where he leads the behavioral health service lines. He also serves on Governor Baker's opioid addiction working group and the Substance Use Disorder Prevention and Treatment Task Force of the Massachusetts Hospital Association, as well as the Hampden County Addiction Task Force. He is a fellow of the American Society of Addiction Medicine, and we are fortunate to have someone of his expertise in medication treatment for opioid use disorder in our region. Thank you, Robert, for all of this.
Good evening. And I want to, unfortunately, Dr. Friedman didn't have the opportunity to introduce himself. But he gave such warm and welcoming introductions to the rest of us. I thought it was remiss that we didn't have a chance to acknowledge both the clinical and the incredible research that he's contributed to this field over the last few decades that has really shifted some of the paradigms about how we treat this disease. So I wanted to acknowledge you for your work. And I will be showing one of his studies on a slide here this evening as well. It's a privilege for me to be able to speak with you about what really has become the gold standard for the treatment of opioid use disorder, and that is the use of medications in the treatment of this disease. And we will review here the evidence for the effectiveness that it's been shown in reducing opioid overdose deaths and opioid-related mortality specifically. Now, it's important to understand first that opioid use disorder or addiction in all of its types is like many other chronic diseases in that it's a chronic relapsing disease. And as you see here in this figure, there is a certain percentage of individuals that we will expect to relapse over time with this condition that is very similar and in fact mirrors almost identically the chronic diseases of hypertension, diabetes, and asthma. We should expect this to be part of the condition that we are treating. But we should also expect, and it's important to understand, that when we employ evidence-based treatments, the success of those treatments can be just as effective as it is with other chronic illnesses that have behavioral manifestations and implications. But it's important that that treatment is applied in an evidence-based way and that it is sustained. Because what we see in all chronic conditions is that before that treatment is applied, the symptoms are high and the risk for complications are present. But when the treatment is employed, those risks and those symptoms decrease. We see this in hypertension with high blood pressure and risks of cardiovascular disease or stroke. But when the blood pressure goes down, those risks go down. But when treatment is either removed or it is not adhered to, we see those risks return. The same applies for the treatment of addiction. Now, when we talk about the treatment of addiction, it is important also to understand that the treatment plan itself can vary by the type. Opioids, alcohol, cannabis, cocaine will have different treatments. It can also vary by the severity, whether it's a mild, moderate, or severe condition, as well as other dimensions, medical and psychiatric conditions, one's level of motivation, their stable or unstable living environment. But we know that addiction is defined and it fundamentally is a condition that has biological, psychological, social, and spiritual implications, and that the treatment must attend to those dimensions to have the full effectiveness. And when we as a community or as providers construct treatment in such a way, it promotes and helps individuals engage in the process of recovery, one that involves the pillars of better health, a more stable and secure home, rediscovering purpose and meaning, and a sense of community. And so while it's true and I believe that one treatment is not right for everybody and there are many paths to recovery, today with the disease of opioid use disorder where the physiologic component is so strong, and as Dr. Friedman mentioned, the element of negative reinforcement with withdrawal, as well as the risks that are present for death when somebody uses more and more, it is very important that we walk away understanding the effectiveness of the use of medication treatment in preventing deaths. And this is a story that is not new. In fact, it's a story that has been going on for many decades. Over 200 years ago, morphine was first isolated from the poppy plant and used as a pain medication for soldiers in the Civil War. The Bayer Corporation then synthesized heroin in the late 1800s to treat cough and pain. Shortly thereafter, doctors and other medical professionals and others realized that this was an addictive substance. And in 1914, the Harrison Narcotic Act placed taxes on these substances, and soon heroin became illegal in the 1920s. What the United States saw from there was over the next several decades, post-World War II and into the 50s and 60s, was an increase in heroin addiction, was an increase in the spread of infectious diseases related to injection drug use that was concentrated in urban centers. And so two physicians, Dr. Vincent Noel and Marie Neiswander, began some very critical landmark experiments at Rockefeller Center. It's almost Christmas. Rockefeller University. Rockefeller University in New York City, using methadone, a synthetic opioid, long-acting opioid, with daily observed dosing, and quickly they saw with heroin users in New York City that it increased stability, reduced the transmission of other infectious diseases, and increased their survival. And methadone treatment, in some respects, was born in 1964. Throughout the 70s and 80s, regulation came into effect, and slowly methadone treatment became more and more accessible. But really, there was only one medication that was available during that time for the treatment of opiate addiction. And although naltrexone was approved in an oral form in the 80s, it really never had wide appeal or utility. And so it wasn't until the Drug Addiction Treatment Act of 2000, DATA 2000, that was implemented on a federal level, where we had another option for treatment. And treatment could then be delivered not only in highly structured regulated opioid treatment programs or quote-unquote methadone clinics, but out of the office. Right? And so in 2000, federal legislation passed and allowed medications like buprenorphine, the medication that is in Suboxone and Subutex, able to be prescribed by waivered physicians out of the office to expand capacity for treatment. And then in 2010, the extended release, long-acting, monthly injectable form of that naltrexone was approved in the formulation of Vivitrol for the purposes of the treatment of opioid use disorder. And so here we are today, right? 2017, having dealt with heroin addiction since the early 1900s, having seen a dramatic increase in the prescribing of opioids for the treatment of pain. We have so many opioids for the treatment of pain that I can't even count them on two hands. There are dozens. And we have 3 medication treatments that are available for the treatment of opiate addiction, which we will review. I present here to you a visual depiction of the natural course of this disease experienced by 581 men with heroin addiction in the 1960s. Without any interventions offered to them, they were followed for 33 years. And it's striking to see, as you follow this out over time, that the preponderance and the most frequent outcome at that point was death. Nearly 50% of individuals followed out over more than 30 years died. Some were incarcerated, some had daily heroin use, some had occasional heroin use, and 22% were abstinent. It's often said that individuals that are sick with this disease end up where? Jails, institutions, or death. We saw that bore out here in this study. And it begs the question that only 6 to 10% of individuals were in methadone treatment at any given time during this follow-up period. And if we had developed as a country a greater capacity to treat and had a greater utilization and acceptance of that treatment, how many lives we could have saved. So as we get into this evidence, I just want to highlight a couple of things again that Dr. Friedman mentioned around the properties of these 3 medications that are approved for opioid addiction. All 3 medications work at the same place in the body, the mu-opioid receptor. And they have various levels in which they exert their effect. Methadone, considered a full agonist, binds to the receptor and activates it fully. So with increasing dosages, has an increasing effect. Buprenorphine is a partial agonist. So it binds to the receptors and exerts its effect to a limited effect. So with increasing doses, there is a ceiling effect, and it has no continued opioid-related effect. And naltrexone, or an antagonist, it blocks the effects of opioids. Binds to the receptors, has no effect. One of the important properties to mention with agonists and antagonists is that agonists maintain that tolerance. right? That is important for two reasons as we talk about opiate overdose deaths. One is that agonist therapy has shown time and time again to be more reinforcing, and so that it promotes people staying in treatment longer than antagonist treatment does. And it also is important because that tolerance is protective against opiate overdose deaths in the vast majority of cases. And when you remove that tolerance, either because you're giving somebody a medication that blocks the effect, or because they've been detoxified voluntarily, you then are potentially increasing that risk. It also is harder to initiate treatment because they must be off of all opiates and no longer have physiologic dependence before initiating it. Now, and those reasons are why opiate agonist therapy really has the bulk of the evidence for success to reduce poor outcomes. It's been shown effective in reducing illicit drug use, reducing the transmission of disease, and reducing opiate overdose deaths. Here we see a study that was done in France, where in many areas throughout the 90s they were seeing spikes in heroin overdose deaths, spikes in injection drug use, and made a conscious decision in 1996 to employ a model where individuals could prescribe buprenorphine out of the office, prescription-based, no limitations, no caps, no numbers. Which saw a dramatic increase in the numbers of individuals treated with buprenorphine that went from 20,000 to 90,000. At the same time, there was a small increase, it's hard to see, in methadone treatment. And you can see the dramatic decrease in heroin overdose deaths. This study, a similar study was replicated, and this effect was replicated in Baltimore. From 1990 to 1997, there was a quadrupling of the heroin overdose death rate in Baltimore. And so Baltimore made a conscious effort to introduce and expand medication treatment. Began with an effort in 1998 to expand methadone treatment. Followed up with a very significant effort from 2006 to 2009 to expand buprenorphine treatment by training physicians, by increasing the number of waivered providers, by increasing capacity and developing what they called medication treatment on demand, which is what we should have. And what Baltimore saw here was a reduction in heroin overdose death rates by half, at a time when almost every other community, including ours here in Massachusetts, was seeing the rates increase. So at a community level, we've seen this impact. Increase in capacity, increase in uptake, decrease in deaths. Another study looking at this in a slightly different way followed individuals that were injection drug users in primary care in Edinburgh, Scotland. 781 followed for more than 27 years, from 1980 to 2007. And looking at this specifically, when you can see here's the top of the graph, the top line represents the greater likelihood of staying alive, whereas the lower down you get, the greater the risk of death. And with individuals during that 27-year time period that received no medication treatment, 25% of them died in 25 years. But individuals that even had less than a year of treatment within that 27 period had a less rate of dying. A year to 5 years, and then greater than 5 years, showing that for every year that somebody was in medication treatment for opiate addiction, it reduced their risk of dying by 10%. This is a deadly disease. I present to you an example. There's many studies that have shown this, but to highlight this, I want you all to visualize 34 people that you know with opiate addiction and living in a community where there's one methadone program. Imagine that this program had only a certain capacity, that it could only take 17 people. And so you had to randomly select. You get to go to methadone treatment, you get to go to regular outpatient treatment with counseling. Everyone, when they entered treatment, was using heroin. I want you to imagine 2 years from now, you called those people to find out how they were doing. You called the 17 people that entered the methadone program. You found that 12 of them were no longer using heroin. One of them went to prison and left treatment. One was discharged from treatment, still using heroin, and 3 were using heroin. Then you called the 17 folks that didn't get into methadone treatment and found that one of them was no longer using heroin. Remember that one. 2 were in prison and left treatment. The 3 had suffered severe medical complications from their injection drug use, and 2 had died. At this point, no longer became ethical to continue randomly assigning folks to the outpatient treatment. And the capacity for methadone increased, and 9 of those individuals were allowed to voluntarily accept and enter methadone treatment. And so 3 years later, you did the same thing and you called those folks. And now of the 26 individuals that were in methadone treatment during that 5 years, you realize that 21 of them had stopped using heroin. 2 were in prison and left treatment, and 3 were still using. And of the 8 that never got into methadone treatment, 5 had died. 2 were in prison and had been discharged, and you still had that 1 person abstinent and doing well and productive. As you might imagine, this was not an exercise that I just put you through. This was a real study highlighting the effects and the effectiveness of methadone treatment that has been replicated time and time again. It's a simple study, but it's incredibly powerful. When folks have access to medication treatment, 80% will typically do well. And when folks do not, think about that 1 in 17, 6%, and the 30% that died. 50 years ago, methadone treatment was introduced in this country, and yet we still often focus, as Dr. Friedman mentioned, on how do we support this type of treatment when we have effectiveness for so many others. Now, this is also the case for buprenorphine treatment. It is not only the case for methadone treatment, although the studies vary a little bit. So imagine 40 people randomized to buprenorphine treatment, a partial agonist, where 20 end up on 16 milligrams a day for a year, and 20 are given buprenorphine for 6 days and then taken off. Followed for a year. Both had counseling, both had drug tests. The 20 individuals that were started on buprenorphine, as the year goes along, you'll see 1 drops out, 1 drops out, 1 drops out, 1 drops out, and by the end, you still have 15. 15 are in treatment, 75% in treatment, 75% opioid-free illicit drug tests. No deaths. For the individuals that received a tapering protocol or a detoxification, none were in treatment at 2 months. 4 had died. When there is no treatment, the risk of death is very high. And thinking about antagonist therapy, this is a study that Dr. Friedman was a part of, a very important study that looked at extended-release injectable naltrexone or Vivitrol given to individuals leaving correctional facilities at 5 different sites around the country and randomly assigned to either Vivitrol or usual treatment and followed over time, with the primary outcome being the length of time to relapse. And using antagonist therapy extended that length of time to relapse, so that the average time was over 10 weeks as compared to 5 weeks. And when followed out over time, that group that was provided medication treatment had less relapse, had less opioid use, and of note for tonight's discussion, of course, less overdose. In that group, 0 overdoses. In the usual treatment group, 7. And here in Massachusetts, based off the Chapter 55 report that looked at data between 2012 and 2014, and individuals were followed out over time after an initial non-fatal overdose, you'll see that the risk for death steadily increases when no medication is received. But when medication like methadone or buprenorphine or naltrexone are given, or the individual is receiving them, that risk stays quite low. Caveat with this is that oftentimes folks, the retention rate in treatment with antagonist therapy, meaning naltrexone, is much shorter than it is with methadone and buprenorphine. And so the median number of months that somebody stayed in treatment with naltrexone actually was 1. And so when followed out after the initiation of treatment, that effect, that benefit actually disintegrated. And so the effect of the naltrexone went away, the mortality benefit went away over time if somebody was no longer on treatment. And so the point of staying in treatment, of having support, of having structure is so important for us to understand. And comprehensive opioid agonist treatment involves all of those elements, which has led to the evidence supporting the reduction in illicit drug use, the reduction in HIV and hepatitis transmission, and most importantly, a reduction in death rates. But it only works, right, as we know, if we have the capacity for people to engage with it. Treatment's only so good if you can actually get it or use it. And a study was done in 2015 that looked back and said, well, what is our capacity? Do we have a gap here in how much opioid agonist therapy treatment is available in the United States? And it looked out and quantified how many people in this country are living with opioid use disorder, and a little over 2 million. And what would be the maximum capacity that we have as a country to provide methadone treatment and buprenorphine treatment? Looking at how many individuals were in methadone treatment, and what would be the maximum capacity of buprenorphine by taking all of the waivered physicians with either 30 or 100 patients and telling them that they were full. And even when doing that and mapping that out over time, even with that expansion, we still were about 1 million treatment slots short. What we know is that about 50% of treatment programs offer medication, which means that less than 40% of patients are offered medications. Less than 5% of doctors are waivered to prescribe buprenorphine, an important treatment in this disease. And there's a dramatically increased risk of death, as was mentioned before, for folks that are both waiting for treatment or those that recently left because of those shifts in tolerance. Yet from that same Chapter 55 report here in Massachusetts, when you look out at individuals after a non-fatal opioid overdose, one of the most critical times to intervene with somebody, we had a woefully low percentage of folks in opioid agonist treatment at 6%. So it only works if the capacity exists, if people engage in it. And so what we've seen is actually increasing effective medication treatment can do a lot for a community. If you have the capacity, if you have the utilization and the acceptance, it's powerful to think what we could do with effective medication treatment, particularly when we consider the high risk of death for folks that are not engaged. We know that medication treatment's not perfect. Right? Medication treatment's not a panacea. It also has risks and complications. It has logistical barriers and challenges. But we do know that it is an absolutely effective strategy to combat opioid overdose deaths. And it's important to recognize that expanding access to medication-assisted treatment is an essential component of a comprehensive response. As Michael Botticelli said when he was director of the Office of National Drug Control Policy, access to medications can often be a matter of life and death. Thank you.